Good day, everyone. I'm Yvonn Jay Guleng, a 3 student, and now I'm going to present you the pharmacokinetics of local anesthetic drugs. Local anesthetic agents are usually injected into a localized area of the body to block specific nerves. The absorption of the drug from the site of injection, drug distribution kinetics, and the degree of biotransformation and excretion of drug and breakdown of products from the body is the primary importance in determining the systemic disposition of the drug and potential for toxicity or the side effects. So now in this figure, this lipid bilayer or the it represents the cell membrane. This blue part is the sodium channel, and the BH plus is the ionized. The BH plus is the ionized form or the cation form or in water soluble. So the B on the other hand is the anionized form or the free base lipid soluble. So this is the intracellular part of the cell membrane and the intracellular part of the cell membrane. So local anesthetic in solution exists in a chemical equilibrium, the chemical equilibrium between the basic uncharged form or the B and the charged cationic form, the BH+, at certain hydrogen concentration specific for each drug. The concentration of local anesthetic dose is equal to the concentration of charged cation. This hydrogen concentration is called the pKa. So this relationship is expressed as pH equals to pKa plus log B over BH plus, or the ionized form over an ionized form. So in this formula, lower pKa means greater fraction of the molecules exist in the anion in the body. So more easily cross nerve membranes, leading to faster onset. The pKa of currently used local anesthetic compound lies between 7.7 to 8.5. Commercially available acids, so that they contain more ionized molecules. Acidosis in the environment into which the local anesthetic is injected further increases the ionized fraction of the drugs. This is consistent with the slower onset and poor quality of local anesthesia when local anesthesia is injected into an acidic infected area.
So in this figure, it shows that sodium channel has two gates, the voltage sensor and the inactivation gate. At resting membrane potential, the channel exists in its resting closed state. So depolarization of the membrane is sensed by the voltage sensor, here the S, and the channel opens, allowing the sodium ions to flow intracellularly within 1 to 2 ms. The inactivation gate closes automatically, so it becomes inactivated channel, allowing repolarization to occur. So this repolarization leads to conformation changes with closure of the activation gate and opening of the inactivation gate within 2 to 5 ms, or known as refractory period. So after repolarization, the channel is in resting state again.
Next figure is lipids. This cell membrane lipid bilayer with sodium channels. Local anesthetics exist in neutral base and an ionized form, or the BH plus. Neutral base is the B, and the neutral form is lipid soluble and easily crosses the cell membrane. So here the B easily crosses the cell membrane. The ionized form, on the other hand, is more water soluble, so it can cause through open channels. The neutral form can cause membrane expansion of the sodium expansion and closure of the sodium channel. The ionized form interacts with its receptor on the intracellular side of the ionized form interacts with the receptor on the intracellular side of the sodium channel. So this is the main topic of the pharmacokinetics, which will be discussed: the ADME, the absorption, distribution, metabolism, and excretion of local anesthetics. So absorption, the systemic absorption of local anesthesia is influenced by many factors, including first, the dosage, which include the volume and concentration, the site of injection. Third, the presence of vasoconstrictor and physicochemical and pharmacological properties of the drug. Many of these factors has also influenced the duration of the effect of the drug at the site of action. So in this figure, this represents the disposition of the local anesthetics within the body following the peripheral administration. So here, the local anesthetic dose being administered into the skin. So it injectate drug pool. So in the form of ionized and non-ionized form. So it binds to the neural tissue, this nerve bind to the non-neural tissues, and on the other hand bind to the neural tissues, which result to neural blockade. And on the other hand also absorb into systemic absorption, the blood drug pool bound and unbound, and results to liver and kidneys that will metabolize and excrete, and vital and response tissues. The organs include the heart and also affects the it also absorbs to non-responsive tissues and lungs, which is the first pass effect. So the rate of absorption is proportional to the amount of vascularity present at the injection site. The faster the absorption rate, the shorter the duration of action of the local anesthetic, and the greater the danger of systemic toxicity associated with local anesthesia. So lipid solubility, again, directly proportional to the potency and the duration of action. The higher the lipid solubility, the more potent the agent and the longer its duration of action. So the pKa correlates with the speed of onset. Drugs with pKa closest to the body's pH have a rapid onset of action, while drug with high pKa have a slower rate of onset. So local anesthetics are poorly absorbed through intact skin, and local anesthetics are absorbed from mucous membranes, serosal surfaces, respiratory epithelium, intramuscular deposition, subcutaneous deposition, and injured skin. Next is the distribution. So distribution is under also in the pharmacokinetics. The distribution of local and the vascularity of the organ. The distribution of ester anesthetics in tissues is much more limited because their plasma half-lives are very short or within a few minutes due to their rapid breakdown by plasma pseudocholinesterase. So what is this pseudocholinesterase? This pseudocholinesterase is a plasma enzyme produced in the liver that is responsible for the metabolism of the common anesthesia drugs as well as ester local anesthetics including cocaine. Distribution of amide-type local anesthetics may be further influenced by anatomic and pathophysiologic factors. So epinephrine is added to some local anesthetics like lidocaine to prolong the duration of action. The local vasoconstriction, which is epinephrine induced by the vasoconstriction induced by the epinephrine, limits the systemic absorption of the local anesthetic, maintaining the local tissue concentration. When epinephrine is combined with drugs that already have a long duration of action like bupivacaine, the effect is less dramatic.
So in metabolism, the breakdown and elimination of local anesthetics are important because of the balance of uptake from the site of injection, and drugs elimination is a major determinant of their toxicity. Next, we have the Esterlink local anesthetics undergo hydrolysis by cholinesterase in the plasma and to a lesser extent in the liver. So what is this cholinesterase? Cholinesterase is the family of enzymes catalyzes the hydrolysis of neurotransmitter acetylcholine and acetic acid and choline, a reaction necessary to allow cholinergic neuron to return to its resting state after activation. So, amide-linked local anesthetics, on the other hand, are metabolized in the liver, which requires conjugation with glucuronic acids. Cats are more likely to develop toxicity from these drugs because they glucuronidate drugs less than other species. So, in amide local anesthetics, cats are more likely to develop toxicity from these drugs. Next, we have metabolism of amino esters like cocaine, benzocaine, procaine, and tetracaine. Ester group is degraded mainly by cholinesterase in the plasma. For endothecal dose, the drug's effect continue until the drug is resorbed into the general circulation. For procaine, example, the products of hydrolysis are the diethylaminoethanol and the para-aminobenzoic acid or the PABA, and can antagonize sulfonamide antibiotics and provoke allergic reactions. For metabolism of amide local anesthetics, so it requires biotransformation in the liver, for example, in lidocaine. The initial steps in the metabolism of lidocaine are done in the liver by oxidative dealkylation by the CYP450 or the CYPs. The alkylation produces monoethyl glycine silidide or the MEGX and the glycine silidide, the GX. So with the MEGX further broken down into the monoethyl glycine and silidide, it should be noted that both MEGX and silidide have sodium channel activity. That MEGX is about 75% of lidocaine, while silidide is only 10%. Next, factors in metabolism of amide local anesthetics. So hepatic disease can degrade microsomal enzyme capabilities. Microsomal inductors like barbiturates also degrade is one of the factors in metabolism of amide local anesthetics. So what is this? Barbiturates. So barbiturates are a group of drugs in the class of drugs known as sedative hypnotics, generally describe their sleep-inducing and anxiety-decreasing effects. So this drug is extremely dangerous because the correct dose is difficult to predict, and even slight overdose can cause coma or death. So microsomal inhibitors like chloramphenicol, ketoconazole, macrolides, antibiotics, metazolam, and verapamils are also factors in metabolism of amide local anesthetics. Next is the excretion. Local anesthetics are poorly water solubles, which limits renal secretion of the uncharged drug. So the hydrolysis metabolites of Esterlink local anesthetics are mainly excreted in urine, while in the amide local anesthetics, they are eliminated in urine or in bile. So the major clinical properties of local anesthetics are based on the following. First, the potency, duration of action, onset of action, differential block, and plasma protein bind.
So first, the potency. It relates to the lipid solubility and the amount of neutral base available at the action site. Both lipid solubility and the pKa promote penetration of the drug to the site of action. Unfortunately, toxicity parallels increases in potency so that relative safety margin decreases. Next is the duration of action. It refers to the length of time of a drug. Length of time a drug blocks sensory transmission depends on how well it penetrates to the exoplasm, or how strongly it binds to the channel, and how quickly it is removed. So for how well it penetrates into the exoplasm, it involves the lipid solubility. The ease of penetration and the amount of drug reaching the sodium channel is a function of lipid solubility. Next, how strongly it binds to the channel. So it talks about the bond strength with sodium channel protein, especially noted with ethylene drug. So next, the how quickly it is removed. So it involves the perfusion and removal. Perfusion is the passage of fluid through the circulatory system or lymphatic system to an organ or a tissue, also referring to delivery of blood to a capillary bed in tissue. So in how quickly it is removed, the final factor affecting the duration of blockade is continued presence or absence in the local anesthetic drug at the site of action. The primary determinant is perfusion at the site of administration and subsequent removal of the drug into the systemic circulation. Next, third is the onset of action. The time of local anesthetic takes place to produce a sensory block is determined by the placement of the drug. The concentration used, it depends on the concentration used, the molecule size, and the proportion of the cationic drug present. The latter is determined by the pKa. So it means the relationship is the lower the pKa, the more uncharged base available to penetrate into the exoplasmic space of the nerve. So for example of onset of action, if the pKa is very low, the local anesthetics will be mainly available in the insoluble form. For example, the benzocaine, which has the pKa of 2.5. So benzocaine is sparingly soluble that is limited to topical mucosal application and fish anesthesia. Next, we have the differential block. Differential block is sensitivity of different neural transmission to local anesthetics is primarily a function of the physical characteristic of the nerves. The general order of decreasing sensitivity is pain and temperature first, and then proprioception and motor functions. So a very important example in veterinary medicine is where the limb nerve blocks have been performed in horses for therapeutic or diagnostic purposes, and proprioception is still impaired. So the horse allowed to move freely. So the horse can injure itself and can injure itself with unguarded movement or foot placement. So it is one of the reasons why racing authorities have banned the use of local anesthetics in competing animals.
So in plasma protein binding, so to be systemically active, a drug must be available to enter sites and potential activity, and in this requires be both unbound and ionized. So the proteins involved with binding of local anesthetics is the alpha-1 glycoprotein. Local anesthetics have high affinity for the former, but is very limited in capacity. In drugs such as bupivacaine, lipivocaine, and ropivacaine, which has a very high over 95%, small changes in percent bound means big changes in unbound drug being available. Events that can change the protein binding include the drug interaction, pH changes, and disease that lower plasma protein concentration. So
lastly, it summarizes all the factors. So, for example, the agent, the procaine, it has the lipid solubility of 1, relative potency of 1, pK of 8.9, and the onset of action is slow. Tissue protein binding is 6, and the duration in terms of minutes is 60 to 90 minutes. So procaine has low potency and short duration, while lidocaine, it has intermediate potency and intermediate duration. So its duration is 90 to 200 minutes. Its onset of action is fast, and the pK is 7.7. Its lipid solubility is 3.6, and its potency is 4. Next agent is the bupivacaine. It has high potency and long duration. It has 180 to 600 minutes duration. Onset of action is intermediate. The pK is 8.1, and its potency is 16, and its lipid solubility is 30. For ropivacaine, its onset of action is intermediate, and its potency is 16. So that ends my topic on the pharmacokinetics, specifically on local anesthetic drugs or local anesthetic agents. Thank you for watching.